morning, everyone. How are you? So, I just wanted to welcome everyone on behalf of Cardno Emerging Markets USA to our event on the Global Partnership. I am the project manager and communications manager for the P4 project, which you will hear about shortly. And we're going to be having an event around PPP scalability, replication, and sustainability, focusing on our mHealth Tanzania Partnership. I did want to also give a welcome to our online audiences and our phone viewers. Welcome, and we will be live tweeting from Cardno's and P4 Project's Twitter handle. So that's at CARDNO and at P4_projects. And also you can mention at mHealth TZPPP also in your tweet, and using hashtag GPW 2017. So also, I wanted to, before we start, I want to welcome Christine Johnson from the State Department. She is the Global Partnership Division lead over there, and she's been working with me to host this event. So I wanted to give her a few seconds just to share more context about what Global Partnerships Week is.
Hi everyone, I'm Christine Johnson, although you'll see me as CJ all over Twitter. I'm in the Secretary's Office of Global Partnerships, and we focus on public-private partnerships. Our main agenda is to directly support the Secretary's initiative and the Tanzania agenda and our objectives. And we actually help to push those forward or resolve issues with public-private partnerships. We also are sort of the hub at state for information on PPPs throughout the State Department and the interagency. We also act as a consultant for the State Department, and we do a lot of private sector engagement. If you ever have interest in public-private partnerships and how to go about it with the State Department, feel free to contact our office. We're the ones partnering with USAID and Concordia to host this whole Texas week. So throughout the week, we're going to have many side events. And if you want to know more about what we do in our office, talk to you, or you can email me, grab my card. There's information about our office on the table. I also threw out there some copies of our Global Partnership Report. It's a great way to find out what's going on through the State Department, interagency, and private sector that was highlighted that focus on the sustainable development, and have done a really good job charging. So we also basically are here to communicate with the private sector on what we do at the State Department and how we engage the private sector. That's it, and I'm really happy to be here and represent our office.
Thank you, Christine. And also I have the pleasure to introduce Cardno's new president, Joe Lowther. He's been with Cardno for many years, and last 7 years in particular, he has led our economic growth practice, and in particular has been the chief priority for the Cardno's business enabling project in Serbia. Joe also brings 25 years of economic growth, competitivity, and
we can't tell what you're saying.
Focusing on PPPs, competitivity, and economic growth. So please give a warm welcome to our Cardno Emerging Markets USA's new president, Joe Lowther.
Day on the job, so it's exciting to meet all of you. As Dan said, I've been out in Serbia working on a project. I did, however, before I took this job and kind of the interim between the end of the project, I got to go to Tanzania. Among other things, I visited the mHealth project, and you're going to hear some really great things that they've done. And I think all of you have been doing some really important work on PPPs. I've not worked on them in the health area. I've worked on the more economic growth side of things and CSR, but I can see some tremendous results coming It's a very exciting area with a lot more potential to scale up some of these things. So anyway, my job here today is to welcome all of you to our office. I'm very glad to get a good turnout out here to Arlington. We are easy to get to from DC and anywhere else. So good. We got quite a few people here. You're going to have a really interesting discussion. This is, I think, as mentioned, part of the CDC. I need to give you the full name of it because I only know of it as P4, but Prevention Funded Cooperative Agreement, Public Partner Partnerships in PEPFAR Countries project, which goes on for 11 years until 2020. And under P4, which Cardno is managing for CDC, there's been over 15, I don't know exactly how many, 15 at least projects in the portfolio, doing some really interesting things that I've seen and showing the power actually of bringing in private side to things. And you'll see from this project, it's really amazing there. The cast that they've brought in to do all of this, and I think it's growing as we speak almost in terms of new partners coming in, both from the private sector, from the government, has been quite strong in this as well here, and NGOs as well, and to say the health sector. So anyway, I'll leave it at that. Again, welcome everybody, and I look forward to a really good discussion. Thanks.
Morning, everyone. I want to acknowledge International Women's Day. And also to thank you and invite you for spending time with us today to talk about PPPs. And my name is Ophelia McMurray. I'm the Program Director for P4, and the full name, like Joe said, is Public-Private Partnerships in PEPFAR Countries. That's why we call it P4. This was a cooperative agreement award under CDC, and Renee has been our project officer throughout since 2009. I've been on the program since 2009, took over as the project director in 2011. So it's been a great journey in collaboration with CDC, and Lauren Marks is here from OGAC. She is the director for partnerships at OGAC, also the Global AIDS Coordinator of the State Department, and we've been working hand in hand also with Lauren Marks. So Lauren, you can wave your hand. Yeah, so I mean, you know, between the two, Lauren and Renee, these are primary clients here, and the PPPs that we manage are on behalf of OGAC and CDC. And as Joe mentioned, we've managed over 15 PPPs during this time. Our first award was from 2009 through 2015, and currently we call it phase 2 ends in 2020. Right now, right now, we're managing 9 partnerships in year 2. We're about to start year 3. And I just want to give a very brief overview before we dig in deep into mHealth Tanzania. That our PPPs that we manage all are very different, very broad. Anything with strategic information, health information, sciences, maternal child health, behavior change, sugar premier that we just went to in South Africa last week. So the ppdsugar.com, so everyone look for that. The premier sugar down south, filmed in South Africa, premieres today actually, for Women's Day. So, and just in case, there are a couple of people in Tanzania that I hope are listening remotely. We have Shri Pereira and Marcos Mizuru, who were very instrumental in the beginning, from the very beginning with the mHealth Tanzania program. So I hope they're listening in. And if so, we appreciate everything that you've done on the program thus far. And it's in very capable hands. It's been passed over to Walter from Marcos, and we're going strong. And I'll leave it there.
Good morning, everyone. Thanks, Ophelia. Thank you for joining the conversation on opportunities for PPP scale-up, replication, and sustained ownership. Like everybody has mentioned, we will be drawing from experiences and best practices of the mHealth Tanzania PPP. My name is Violet Katani, and I'm Cardno's program manager under the P4 program. I'm also joined here on stage by PPP practitioners who are also partners on the mHealth Tanzania to my left, from the public sector side, I have Ms. Renee Sanders. Ms. Sanders is a senior public health advisor with the U.S. Centers for Disease Control and Prevention. Next to Renee, we have Mr. Walter DeSanjo, who's with the Ministry of Health. I have to say this right. Ministry of Health, Community Development, Gender, Elderly, and Children. And he's a system analyst from there. From the private sector side, we're joined virtually by Diane Sang. Do you have Diane? Yes. And Diane Sang is the engagement manager with GSMA. And from the practitioner side, we have Ms. Yanida Ferentinos. Yanida is Cardno Tanzania's country manager. She also heads up the mHealth Tanzania program. So welcome, everyone. So I would like to start by contextualizing this discussion with a brief video on mHealth Tanzania. So maybe we could take a second to watch it.
In October 2015, the mHealth Tanzania Public-Private Partnership celebrates reaching 1 million registrations to its Healthy Pregnancy, Healthy Baby text messaging service, also known as Wazazi Nipendeni in Tanzania. They reached this important milestone thanks to the comprehensive and expanding partnership model, where each partner leads one or more components to implement the Safe Pregnancy and Motherhood SMS service across Tanzania. Partners support the technical implementation, the zero rating of messages, the multimedia campaign that drives promotion of the service, as well as the registration of men and women in villages and health facilities. With the Ministry of Health and Social Welfare providing leadership, these partner support and resources have facilitated 55 million free and safe antenatal, motherhood, and infant healthcare messages and reminders to be sent to both men and women. The SMS service is making a huge impact in the lives of everyday healthcare workers, pregnant mothers, mothers with newborns, and male supporters alike. The Ministry of Health is doing a great job by having Wazazi Nipendeni, because most of them, they don't know anything about health delivery or health preparedness. They don't know anything about it.
There are a way of educating your patient without meeting them in person. Otherwise, you have to see all the hundreds in your clinic, which may not be possible.
Getting ready for their back, like also the second time we go there and work together, we can really be repeating the point of theory and use message ilikuwa imesema kwamba mtoto sasa hivi amegeuka kichwa cha chini tayari kwa kutoka. Kwa hiyo unaweza kushindwa kutembea na ndugu yapenda inaona. Kwa baada ya kupata ile message ilifaidia kwa sababu mbona ishara ni ngumu.
For the last 10 years, the mother-child health projects in this country have improved very much, although we have not reached everyone in the deep village.
Thanks, Greg. So I would just like to say that since the video was made in 2015, we've actually reached 1.6 million subscribers on the program. And the Wazazi Nipendeni program is just one of the many programs which are hosted under the mHealth Tanzania PPP. We also have an M-Nutrition program, and we also have an HIV/AIDS messaging program. We're also supporting the ministry with the Integrated Disease Surveillance Response Program. And next year, we're earmarked to launch our HIV/AIDS appointment reminder program. So a lot of programs that are going on. As we know, PPPs have become a top agenda on many international health programs. PEPFAR actually articulates the recognition that PPPs make towards improved impact and efficiency in strengthening health systems in Africa through its PEPFAR blueprint of a shared responsibility agenda. And PEPFAR has engaged in close to 300 PPPs, and I'm looking at Lauren because she can correct me if I'm wrong. Engaged in close to 300 PPPs since 2006. So even though it's a relatively small, short trend of new trend for PPPs for PEPFAR, these PPPs have demonstrated significant impact. We found out when the private sector core competencies and expertise has been paired up with the market failures within the health system. But despite the success that PPPs have shown, there's a lot of questions surrounding how to maintain, measure them, and govern them as well, and making sure that we scale them up beyond pilot programs. But we're fortunate enough today to have on our panel experts that can speak to some of these things. So we will be, for this discussion, the panelists will be taking a question or two from me, and then we'll open it up to the audience for questions as well. But before we do that, I would like each of the panelists to introduce themselves and what they do within the space of PPPs, starting with Ms. Sanders.
Good morning, everyone. It's a pleasure to be here and to have had the opportunity to work with Cardno since 2009, and that's when we formally at CDC, within the Division of Global HIV and TB, initiated a cooperative agreement to manage, implement, and evaluate public-private partnerships. We're in our second phase, as Ophelia said. We're in our last 5 years, and I promise them when they end that cooperative agreement, I get to retire. So it's been that long, but it's been a great relationship, and we've seen the portfolio within CDC, especially at the field level, grow over those past 8 years. I serve as the project officer for the cooperative agreement. I also work closely with Lauren as her co-partner in crime, as the co-chair for the Public-Private Partnership Technical Working Group. And I also serve as the point person within CDC for public-private partnerships.
Good morning, everybody. I'm Walter. I've been working with the Ministry of Health, Community Development, Gender, Adult, and I've been told how to use this mic. So I've been working with the Ministry of Health, Community Development, Gender, Adult, and Children for almost 7 years. And one of my major responsibilities is to oversee the implementation of ICT activities in health sector, especially mHealth systems, which we are using them to collect information or data from facility level or community level all the way to national level for better decision making.
My name is Yanita Ferentinos. I am the Cardno Tanzania country manager, and I oversee the mHealth Tanzania PPP program, which facilitates, identifies, and coordinates partnerships for mobile health services in Tanzania that are owned and led by the Ministry of Health, and our program is financially supported by CDC.
So Diane, can you hear us? Maybe you would like to introduce yourself. Diane, you're on mute. Can you please turn off your mute? Start again. We can't hear you. I promise you, we tested this yesterday.
Well, you can start also with that if you like.
No. I know this. I know everything from this.
Yeah.
Where is she sitting right now?
Diane is in Nairobi.
Okay.
Yes.
So maybe we can continue with the discussion and.
Yeah, Diane, are you called into the phone number?
Work on that. It has nothing to do with the platform.
You continue, Bob.
Okay, yeah. So we will continue with the discussion, and Diane, when we have sorted out the technology, then you'll be able to join back in. Apologize for that. So I will start my questioning with Renee. Okay, so Ms. Sanders, there's a lot of
We went
questions.
from Renee to Ms. Saunders, okay?
Okay, serious.
You can't do the Renee thing.
So Renee, there's a lot of questions about the value of PPP. Can you talk about what CDC and by extension the U.S. government typically look for when engaging in PPP?
Okay. Well, when we talk about PPPs and we look at the hallmarks of PPPs, we're looking at being able to pilot new and facilitate the scale up of existing interventions. And we also look at leveraging significant private sector resources to support that. So it's a partnership in the sense that there's shared responsibility. It provides us with an opportunity to extend the reach of programs and messages. It also speeds up the responses and the innovation cycles. It also allows us to connect with organizations that share our goals in terms of making a difference in terms of public health and making an impact in public health. We gain a lot from the private sector in terms of their perspective and different strategies and approaches. They also provide a different problem-solving or approaches, as Yanita can attest to, and it helps strengthen our workforce as well as the implementing partners and actors and stakeholders. And it also gives us an opportunity to raise the awareness of our work in the field.
Great. So if you allow me to ask a follow-up question on that, as you know, PPPs can take different forms. There are the large ones with the big multinational private partners, and then there are also the local ones with the local private sector. Is there a preferred model for CDC or USG?
That's a trick question. And don't quote me on this one, and I won't do a tweet on it. But anyway, I would have to say that I think I've seen the benefits of all the models. So we have a combination of global PPPs, which are usually centrally funded. We have country-held PPPs, and we have headquarter-held PPPs. And I would have to say that as you're here today, mHealth Tanzania started as a global PPP, formerly called Phones for Health. Don't shoot me if you're part of one of the early implementing partners, but it grew from being global to country held, and that was at the request of the Ministry of Health. We didn't have that long title then, but it was just the Ministry of Health. Through the collaboration with CDC Tanzania in the field, and then it grew from being a country health to something that's shared between the Ministry of Health and now is growing partners. So that is a situation where it is more from being centrally held to now being more locally held and much more consistent with PEPFAR's emphasis on country ownership. We also have PPPs that were generated at the country level. And I find that they tend to be more sustainable because they have to use their resources from the beginning. I think most of our PPPs that start off as being global, sometimes it gets spoiled by having the funds and not wanting to invest their own funds. But when you have a country that has already interest, identified a need, has identified the partners, and is willing to take some of those dollars out of that pie, you find that those tend to be much more sustainable because you also have a champion within the USG that is going to support that PPP, who's going to look for opportunities to grow the PPP and look for other partners. And then we have the headquarter held ones. Now, they're almost like the global ones in a sense, in the sense that they're removed from the actual implementation, and there still is a false sense of security at the field level in terms that the funds are coming out of the headquarters operation plan as opposed to the country operation plan. But those tend to provide an opportunity to reach a broader base. They tend to be much more technical and focused. And so I would have to say all three of them really have its plus and minuses, but my preference, if I may say, is a country held PPP.
And why is that?
Because they're sustainable. You find that there's a closer working relationship between the country, the Ministry of Health, and the implementing partners. And it's closer to addressing the needs because they're there every day. Mm-hmm. And so it changes over time to be able to address those specific needs that are identified.
Mm-hmm. And when you say that, it's like you're describing the mHealth Tanzania Partnership.
Yes.
So, which is very good, which leads me to my next question for Yanida. What Renee has just described seems like a very complex systems in terms of the partners and the ability to scale up and managing all the different risks as well as shared value. Can you describe to us the structure for the mHealth Tanzania PPP and how you ensure accountability as well as shared value across all the different partners?
Yes, the way the mHealth Tanzania Partnership works is that we identify the partners together with the ministry. We look at the needs of the end users, the needs of the stakeholders, and I'm actually looking at people in the audience here who have been part and parcel of it, who have now have been partnering with the program from that point of view. There are people, for instance, if you look at organizations that work, for instance, in the field, we have the NHIF, National Health Insurance Fund in Tanzania, that it has been given funding from a foreign entity to bring free health insurance to the end users in certain regions. Now, we are implementing, together with the Ministry of Health, the Tanzania SMS service, which brings safe monthly messaging. So we're looking at these synergies that are there. Clearly, for the health insurance, it's of vital importance to keep their patients as healthy as long as they can, so they can not pay out those benefits, but keep them as healthy and just make sure that they come to the clinic when it's really absolutely necessary for them to receive the care that they need. So when they register these women for the free health insurance, automatically health messaging. When you look at those particular interests of each and every single stakeholder partnership, you put that in an MOU, you write down every single resource, investment, and roles and responsibilities. And that's how the mHealth Tanzania Partnership manages this. Together with the Ministry of Health, we make sure that those interests are all clearly outlined. We have currently about 26 partners that are actively been looked at and are working in Tanzania, and out of those 26, only one in the past, how long have we been doing this? Since 2011, actually. Only one ceased to work with us because they're funding. But even that partner didn't really lose us. We didn't really lose that partner because it was a sub-organization of a health institute, and the mothership, the health institute, like the Aga Khan Health Services, took over the program. So in fact, out of the 26 partners that saw the shared value of working together on mobile health services, all are still there. Does that answer the question?
I mean, it's very interesting to me how you can get a broad range of partners from public, private foundations, all with varying interests, working on this Tanzania program since 2009. It's very, very fascinating to me, and we would like now to put Diana into the conversation from the private sector side. Diane, if you could introduce yourself and what you do with GSMA.
Yeah, sure. Can you hear me now?
Yes.
Okay, fantastic. I think I let down the private sector there for a bit. My name is Diana Sang. I'm a market engagement manager with the GSMA, working on our current project in Malawi and Tanzania. The GSMA is a global association of mobile operators that encompasses around 800 mobile operators globally and around 200 players in the technology space, mobile phone producers and developers as well. Our current project in Tanzania is focused on leveraging the mobile phone to increase behavior change and around nutrition and knowledge awareness. So that has been the project that we have been working with the mHealth Tanzania PPP for the past 2 years. And it revolves around developing and customizing content on nutrition that is applicable to the different profiles and demographics in Tanzania, and then using their platform and their SMS service to disseminate that information.
Great. And just so we know, the partnership has managed to negotiate with the mobile network operators in Tanzania to zero rate the service for the subscribers. So this means that the subscribers are receiving those messages or the service free of charge. And that is no small achievement, and would like to congratulate the program as well as all the partners in making this service available for free to the Tanzanian population. So Diana, with that, the mobile network operators in Tanzania obviously provide valuable ICT tools to enable increased reach in Tanzania. Could you tell us why they do this?
Yeah, sure. So the mobile sector and the mobile industry has been changing quite a lot in the past 2 years. And I think now it's moving beyond the boundary of just offering traditional telecom and media solutions. And then it's growing into a bigger ecosystem focused around connectivity, content, and other digital services that link it to other sectors. An example of the growth from this space is that nowadays there's less competition amongst the mobile operators from voice services and basic SMS services, but it's now growing into services that can bring them more closer to the users and also help them reach markets that have not been addressed before. In this case, rural markets would be the best example that I'd give. So there has been the interest from the operator space has been growing, and I think the opportunity that PPPs give to mobile operators is just breaking out new business models and new partnerships that can help them to now penetrate their markets further and reach users faster, and also customize the services better for different demographics.
So what I'm hearing you say, Diana, is it goes beyond just corporate social responsibility. If I'm getting you correctly, they're also interested in maintaining their base as well as expanding their base through some of these programs. So is there opportunities for replicating the mHealth Tanzania to other parts of Africa where GSMA is currently engaged?
Yeah, definitely. The example and the success of the Tanzania Partnership in the health sector, I think it's a great example that other sectors can replicate. A lot of public health areas and the public sector specializations are governed, and the government sets the agenda and creates an enabling environment around that. So when it comes to energy, when it comes to agriculture, when it comes to financial access and inclusion, there's a very big opportunity to work closer with the government and private sector. And I think the example of how the mHealth Tanzania have leveraged the PPP model in the health sector, I think just shows how much more can be done across Africa as well, based on the successes that they've had.
I have one question, maybe for Walter. Walter, we know that the ultimate success of a public-private partnership is the transition from donor-funded or to country-led or country-sustained programs. Could you tell us a little bit about what the Ministry of Health is doing in Tanzania to ensure sustained ownership of the program?
Yes. First of all, we have got policies, standards, and guidelines for developing and implementing any ICT initiative in the country called mHealth systems. So before implementing these systems, we have to make sure they meet these standards and guidelines. Also, the government or ministry has already invested in the setup of mobile health platform, which all mHealth systems must link to the platform, of course, via official ministry shortcode. And this platform is already connected to all major telecom companies in Tanzania, which will aid in the process of scalability and the sustainability of this system. Also, we established a very strong PPP model, whereby we create opportunity for value shared activities, which encourage private sectors to invest into our mobile systems and make them sustainable. Also, ministry is take these PPP initiatives very seriously. since they help the ministry to collect information from community and facility level. When we say facility level in Tanzania, most of the facilities are found in a very hard to reach areas. Most of them, they don't even have electricity, internet, and infrastructure is not good or it's not good for to ease somebody to travel from facility to districts. Some of these facilities, they are almost 300 kilometers from districts. So you can see how hard to collect data from such kind of areas. So that's why ministry is taking very serious to these initiatives and use them to collect information and data from a facility to national straight, but of course via district level and regional level for better decision making at all levels. I insist for better decision making at all levels.
Great. So I'll ask our panel one last question, and please feel free to answer. When you look at the Tanzania model, from where you're coming from and your role on the partnership and within the global PPP space, could you talk about some of the success in the model itself and some of the opportunities for scale up or improvement, particularly of mHealth Tanzania PPP? Anybody could jump in.
I'll start off first. As you know, I told you that the mHealth PPP was a global PPP, then it went to country health. Now there's shared responsibility with the government. Last year when we were discussing the development of the new platform for mHealth, this was the first, and I've been doing this for a long time. The government of Tanzania invested funds in the development of that platform. So already they made an investment, they had made a commitment, and as you can hear from what Walter said, now they've standardized protocol around the development of the and use of the platform, as well as making it the focus for decision making and data collection.
Add something to that. Sorry, I have to use the microphone because my voice is like ultra low. Yeah, that is part and parcel of the approach in Tanzania. I think what makes Tanzania so unique, okay, I'm biased, I live there, but the community in Tanzania, the mobile health community in Tanzania communicates. And that is something that I think is specifically special because it communicates under the leadership of the Ministry of Health. What we have is a community of practice for mobile health practitioners. We speak how often do we get together? Marcus is on the line, he should know, but every few months we all come together and we discuss what is going on in Tanzania. What should we do? What does the other person do? Where is he? In which region is he? So there is no competition, and there is geographical distribution of activities, and there is linkage. I think the magic word is not to compete, but to link. For instance, when we look at, I can only use the Tanzania as an example, instead of organizations coming with the same safe motherhood messaging, they're now thinking, look, how can I, and this is how GSMA came to speak to the mobile health practitioners and said, hey, we would like to have access pregnant women and give them nutrition information. Why not link to the Wazazi Pandemic? And that's how the communication started. And this has resulted in revision of the nutrition messaging within the Wazazi Pandemic, expansion of the content, and investment from the Mobile Operator Association into promotion, marketing, communication with the government, you name it. It became a large project, which would never have come together if there had been let's do it on our own and let's pilot this. We were already at scale. We already had reached, by the time that the GSMA came in, we already reached 1 million subscribers in a country of where we have 1.8 million pregnancies in a year. So the scale is there, and the partners who come in are non-competitive. We are supporting them into their programs, and they are supporting the ministry in scalability. And that, I think, is part and parcel of the success. That now the mobile health platform is now a nationwide mobile health platform owned by the government, shows that the leadership of the government is very much there, which is another show that how powerful this coalition is.
Diane, do you want to weigh in?
Yeah, and I think if I could add on how easy the PPP model in Tanzania made it for private sector to even support more, is that I think for players, especially for example, the GSMA, who are coming into a country, we are not based in Tanzania, where we have our Africa office in Nairobi, and we'd like to support maternal nutrition. We need partners who already have links to the system, who are already approved by the government. And had the PPP model not existed, I think we would have seen another pilot again in Tanzania, and which would have replicated a lot of what the Tanzania Partnership are doing currently. And we're all targeting the same users. We're all trying to reach pregnant mothers and mothers with young children. So I think the support system and the guidance from the Ministry of Health on first thing, they let us know that, hey, we already have an mHealth platform. We already have someone working on maternal health. Find a way to link to their system and improve further on what they're doing. And that's how we came into the partnership with mHealth Tanzania. And you can actually see it builds on what has already been done. And now as other partners come in, other projects, other innovations actually from the private sector linking and building onto that platform, it just keeps getting stronger and without overwhelming the user at the very end.
And I think the strength of the partnership is how it began. The fact that there was an equity among all the partners, and there was a respect, and that laid the foundation for the partnership to grow and to scale up.
Great. So thank you, everyone. I would like to open up the floor for some questions right now for our panelists. Can I have it? I'll bring it.
So congratulations, first of all. My name is Susan Ray Ross. I work for USAID doing public-private partnerships, and I manage the MAMA pension program. And so I'm wondering if you could maybe go back to the early days, because even though we have net zero rated rates, in none of the countries have we been able to get completely free. Even South Africa, where the government has been very active with Mom Connect, they are actually paying for the text and voice messages. And so we have had lots of discussions with GSMA as well as the different MNOs in country. And I do think that we're moving to a point where the phone will become a commodity, and the idea of you will actually make money on the services. But I think that even trying to tap into the universal service funds has not proven successful in many of these countries. So if you could maybe take us back to the early days of how did you engage the MNOs and kind of get them on board? And then my second question is, in most of the countries that were, except for South Africa, we've really found that people need voice because the literacy rate is very low, particularly in Bangladesh, almost all of it is voice messages. So how were you able to think through that you would really need text, and kind of what was your thought process?
That's great. Thanks, Suzanne. That's a great question. So, Yanida, do you want to start off with how did you manage to secure the zero-rated agreement?
Yeah. Actually, to go back, I know the ladies from Moms Connect very well. We actually worked with Mama very closely when we were doing the content development. So we know the story. We know and we have been discussing with them quite often about how the zero rating came about, and it didn't come about in one day. To give you my background, I'm ex-telecommunications. I used to be the CCO for one of the larger mobile operators in Tanzania. I'm not a health expert. I became a little bit of that over the years, but I'm not one. We have our own health people for that. So, of course, I went straight back to my old bosses when we started with the concept of planning and healthy pregnancy, healthy baby as SMS service. And that was when we started. It was to support the multimedia Safe Motherhood campaign, which in the meantime has ceased to exist, which was USA funded, by the way. And we continued under the name. The first year that we started, we went to the mobile operators to say, look, we've got a business case for you. We would like to do this. Unfortunately, we did benchmark against Bangladesh. We benchmarked against what was happening in South Africa. And we found the mobile operators non-responsive. They said, bring us a proof of concept, which if I had sat on the other side of the table, I would have said the same thing, but we gave it a go anyway, trying to get the zero rating or at least bulk pricing. But you can't do bulk pricing if you haven't gotten started yet. So fortunately, we had CDC on our side who agreed to fund the messages for year one. And said, right, see how you go, try and get this relationship with the mobile operators going. So the first year of Bangladesh and the first year of Moms Connect, back then it's Mama, was about between 100,000 subscribers in a year's time. So we budgeted for that. So the health pregnancy, health baby SMS service kicked off. We budgeted for that, and within 11 weeks, we had 100,000 subscribers in Tanzania on SMS. You celebrate for 1 minute, and the second minute, you go like, oh my God, we don't have money. So we went back to all the mobile operators and said, look, it works. Look at it. Now, can you give us out-of-box pricing, or can you give us zero rating? And most of them said, well, you know, let's have a look when you reach 250. One of them said, you know what, that bill we sent you, so when one comes, others will follow, isn't it? When you build it, they will come. So the first mobile operator, that was Airtel, not the one that I used to work for, Airtel, said, okay, we'll zero rate from day one. When Diana's not on the screen right now, but once we've reached 500,000 subscribers, GSMA was as nice to nominate us for an award that would say that we were actually one of the four most successful mobile health services around the world. That's the day that we got all the phone calls, that we got all the zero rating with all the other mobile operators, because the proof of concept was right there, because the Association of Mobile Organizations said, yes, this works, this is sustainable if the mobile operators are there. And from that day onwards, the partnership was bound with the mobile operators. And by then we had already in place lots of health organizations implemented on the ground, doing the registrations through health facilities, community-based registrations through community health workers. So that's how it came about. It's not an easy case, and when people say we would like to start a pilot won't tell you your proof of concept. It will tell you if you do it at scale, and if you do it as if you were to go to scale. So with Moms Connect, I do believe they still have that chance, but South Africa, for instance, is a very, very complex setup when it comes down to the way it's set it up, with the ministry leading it as well, but the ministry implementing it. It's different capital allocation, as we say. But the business case is there. And I would like to emphasize for all those listening from NGOs that once you speak to the mobile operators, a lot of NGOs go there and say, we have this wonderful program. You need to give us X, Y, Z. But you have something in your hand that is of value.
Because when someone zero rates, and one of the mobile operators, I believe it was Diego, Mr. Diego from Tigo, the managing director of Tigo, he said in July at the GSM conference, zero rated services bring in the money. Why? Because those people who normally would be on your service, they don't use the telephone because they don't have the funding or they don't see the value. Once you give them zero rating, they're receiving those messages that actually encourage them to use the voice. And so it is a business case you can make. It's a retention, but it's also marketing. So when you are as an NGO go and you would like to make a deal with a mobile operator, you do have a marketing proposition for them, a business case to make. And this is where the power comes in when you have multiple partners. If you do it by yourself, you just alone them. When you are in a partnership, this is what we're trying to do with the mobile operators together with the health partners that we are now gathering on one platform to strengthen numbers. It's not just, it's a one-stop shop, it's also strengthening numbers. When we're all sitting on the eGov SMS and the eGov USSD, one price for all, or specifically organized, regulated, it is much an easier case to make. And that's where sustainability comes from. I want to go back to the voice as well. We are working on voice, but SMS in Tanzania is actually the largest SMS country in East Africa. Because it was so cheap in the beginning, it's cheaper than voice, so people have gotten used to using SMS very well, but voice is still very powerful. We are talking to partners to adding the voice component, but we're linking to partners who have voice. So, yeah, that's our story from the beginning. So you always have to stop me when I start talking.
Thank you, Yanida.
Hi. So I'm trying to understand the technology. I don't need it. I'll speak. Whether how sophisticated or not sophisticated it is. So when these villagers or the mothers receive text or send text having a certain problem, is that captured and some kind of profile is created for each individual, or is it just a one-to-one, one question, one-off approach?
The registration to this particular SMS service, because there are several services, we're focusing a little bit on those as many right now, is that because our partners are in the health facilities or in the villages, sorry, I keep looking at them, they used to work with us as a partner. When they're in the villages, the healthcare worker, for instance, sees a pregnant woman, says, look, it's important for you to have safe motherhood information. Can I register you to the 1000 Tanzania? She will say yes. They will say, what is the phone number you use? They will take the phone. They will then send a message to a particular number, which is the short code that we use. And there's simple questions we ask. Very simple. So we do create a profile, but we don't need to, we don't want to scare people. We've done extensive testing on that, of course. We don't want people to think that it's like a big brother's watching you idea. So we ask them the age. When it comes through the healthcare worker, we ask a little bit more questions about see how old is she, the age, and the healthcare worker identification number, so that we can track which how many each healthcare worker has registered. So we do know that if, for instance, you're 3 months pregnant, if you're 3 months pregnant, you will get on a time schedule. If you don't go through the healthcare worker or the health facility, you can register yourself as a pregnant woman because of the media who has told you to register, and there was a very large media campaign, and lots of people still remember it, and it's being continuously ongoing. You will then send your keyword to the short code, and you will be asked the same questions. Are you a pregnant woman? Are you a mother with a child? Are you a supporter of a mother with a child? Because we're not just focusing on the women, we're also focusing on the support network. Or are you just someone who looks for health information? We do that for those who are too shy to say what they really are. So they may start off with simple health messaging, and then we see them upgrade. Sometimes they say, actually, I'm pregnant, so they re-register as a pregnant woman. So the questions that are asked are very simple. are you, how far along are you? And then the messaging is push messaging. What we do after a certain time, you're registered, let's say you say the 3 months, we ask you to go to the AMC clinic and find out how far along you really are. Because we do find people don't really know how far along they are. So it may turn out that they're 6 months pregnant after all. And then they upgrade their subscription. Yeah.
One last question. So I know you said the data, the text messaging is free, so are they required to buy the apparatus, or is that also the actual cell phone, the mobile phone? Do they buy it themselves, or do you just give it free?
That's actually a very good question. In Tanzania, the mobile penetration is very high. 60% you will say, 60%, 63%. Yeah, you will say that's not that high, but actually when you look at the Gates Foundation research, it's not the ownership of the mobile phone that counts, it's the use of the mobile. And that Gates Foundation research is actually about mobile money. In Tanzania, that is very, very highly used. I can use any phone for that. So in Tanzania, about 90% of the population has used the telephone within a week. So I may use his phone to receive my messages. He may either register as my supporter, or I may register on his phone as being a pregnant woman.
Does that mean you have separate SIM cards, or you use the same?
That is it's very common in Tanzania to have your own SIM card and just put it in his phone.
Okay, so are there any questions, any more questions from the audience before we go to online? Yeah.
Hi, Walter, can you elaborate a little bit more about the commitment of the ministry for this platform that the mHealth Tanzania is on, and specifically the permanent secretary's commitment and the use of data?
Yeah, with this platform, first of all, as I said before, government invested in it. So with this platform, this platform will help us to do some sort of analytics by mobile telecom, or by program, by messages. So it will help us to get clear information from the users that, let's say, how many pregnant women are registered, how many pregnant women give birth. So with this platform, we can get all the information we want. And this platform is going to be connected to the larger health information mediator, where all for many health information systems are going to be linked or integrated.
Any more questions from the audience right here? Or can we take a couple of questions online? Yes, that's the first one. How is the government in Tanzania able to make these mHealth programs sustainable, specifically regarding obtaining the buy-in of the MNOs and incorporating mHealth program budgets into the ministry's budget, especially since SMS costs are quite high? Are there other key role players that also cover these costs? May we know who's sending that question, Greg? That's from Vincent LC. Not sure where that's from. I'm not sure who would want. Walter, I think that's a question for you. How has the government in Tanzania been able to make this mHealth program sustainable?
Yeah, I think we can both answer that question because it's a bit, it's got two visions on this. Since the mobile operators already see the value of this collaboration, and they encourage the mobile health platform of the Ministry of Health, that where everybody will link into and can use, is not obliged to, but can use or can even build upon So if you have a mobile health initiative and you would like to start that, you can either choose to put it on the mobile health platform of the Ministry of Health and enjoy benefits of that. Or if you have your own platform, you can build it on your own platform and link to the Ministry of Health platform. But at all times, you would have to go through the eGov SMS and eGov USD to enjoy those rates. And then you would also be recognized by the Ministry of Health and you would be under the umbrella of the Ministry of Health. Am I correct?
Yes, you are very correct. And if you are going to use our Ministry official code, it's going to be easy to scale up system because it has got most of the system. They got zero rated by using this shortcode.
So we do have a follow-up question, and then we give a follow-up.
All right, so we will take the follow-up question from Vincent, and then we'll go to Obi. Have these PPPs also explored other mHealth platforms that are more cost-effective as the penetration of smartphones is increasing, in this example, in the African continent, and while the number of both basic and feature phones is decreasing? I think that's the question. Taking into consideration that data has become more affordable and more cost-effective rather than SMS or USAI or USSD or voice. Have you explored other mHealth platforms, Tanzania, which may be more cost-effective? I think you can talk about, maybe Renee can talk about the cost-effectiveness of the mHealth platform or the mHealth Tanzania PPP, or Yanida.
There's 3 questions in here, actually, that I can see. So I just want to maybe already tackle one. In Tanzania, the use of the smartphone is actually quite low for the target group that we're looking at. When we look at the data for the Wazazani Panani, only 15% is urban. So we're really looking at the underserved areas where we do have our registrants. So they do not have a smartphone. And our system is SMS USSD based because that can go to any particular phone. Any phone will receive that. Voice, of course, would also, but voice in Tanzania is very expensive. So for us to use that, we need to partner with someone who's already set that up and already has a sustainable model and link to it. So join forces again. Good marriages are the ones that stand together strong. And we are looking for those marriages. We are actually very big jointly. So it's very strong. And I think the question of platform, depending on what your definition of platform is. For us, definition of platform is the system upon which the mobile health services are residing, the technical platform. That's what we look at. So what I think in here, the definition of platform would be what kind of type of services would you be looking at? And so I think I've answered that there.
Yeah, and Vincent, just to add into that, you have to remember the model through which this program is being delivered in. It's a public-private partnership. So we are leveraging resources from a number of partners, and by definition, we're leveraging economies of scale. So it's cheaper for any one partner to implement a similar program than they would have done had they delivered this in a traditional program.
Hi, this is Steve Ellis, and sorry, I'll chip in here. I was working with Dimitri in Tanzania for a good number of years back, and just a related question was, and I think one of the strengths of the partnership, as well as the platform, was the ability to accommodate some of these changes. So yes, as smartphones became more available, having a platform that different systems and different partners could access. So having ways where if there were community health workers with different applications, or facility-based health workers who were seeing some of the same women, there was the ability to, rather than have health workers or women have to double or triple register, and everyone's already overworked and we're struggling to get people, was to be able to accommodate these different platforms so that health workers could do less work and we could actually find ways for the community to come together and take advantage of all this interconnectivity. So they were able to leverage the use of smartphones as that is becoming more prevalent in both community and facility-based programs to still access the same platform without having to build something new.
Thank you.
So one last question from online, from Obi. What are the major concerns you've encountered in Tanzania and how did you overcome them? Would be nice to document lessons learned. And Obi is with the Health Informatics University of New England.
How long do you have? I think there's time. I think time is one of the most important things that we need for this. Time is really, like I said, the first year was the toughest because you need to have your proof of concept. You need to make your business case stand. And that was the largest obstacle we had, to fight for those zero ratings, to fight for both sides first and then to fight for zero rating. The other obstacle is competition. Let's face it, people, this health sector, and I'm not from the health sector particularly, so I'm allowed to say it, it's very competitive, very protective. And yes, I'm from the telecom industry where we're very competitive as well, but we know how to just them, right? And we know how to work together. And we see now slowly this health partners understanding that working together, and together we're strong, and together we're getting things scalable and sustainable, and it's slowly getting there. But it's been an obstacle in a way, but I think it's also it's been a working point. Let's go with that. The community of practice, and I would say for lessons learned, I think the community of practice of Tanzania has been key to resolving those communication issues that were there to ensure that people saw that there was no competition and collaboration. You do not need to compete. You do not need to do your own thing and then later on say, well, which one of us is going to take that region or which one of us take that region. No, we're together, we're strong. Do you want to say something about this? The ministry came in.
Yeah, with this, we have got the community practice where all MS partners, MS implementing partners, I don't want to say they are reviewed, but this community of practice is taking care of all these initiatives and advise the government, of course, by Cardno or the practice, the community itself.
And I also say one of the earlier challenges of the partnership was essentially in building the partnership, building those type of long-standing relationships between government, the stakeholders, CDC Tanzania, the ministry. So it took a while. It took a good 2 to 3 years just to build those type of relationships. And I think that most people do not realize that public-private partnerships is labor intensive. Very labor intensive. You can't just put it on remote and let it go by itself. You have to nurture it. Just like Yanita said, it's like a marriage, it's like a relationship. Sometimes you want to quit it, but you come back and hit it. So, it's that type of situation.
Thank you, Renee. Diane, I think, do you want to weigh in on the constraints and how you've been able to overcome them?
I think I will talk about one of the constraints that other partners normally face when working with mobile operators. And it is understanding and it is just that initial engagement with mobile operators, especially for players from the development sector and public sector who are not used to the, I think the very rigorous pitching that happens with mobile operators is not easy for most. But I think the Tanzania Partnership managed to learn how to overcome that by finding out what operators want. That is the question that they always ask, like, what's in it for me? And mobile operators speak numbers. And the two numbers that they're most concerned about, regardless of the partnership, regardless of even the sector or the product that they're working on, is one, revenue, of course. And in many cases, that has been the first one. But then secondly, they're also very concerned about their subscriber base. So as much as they want to increase and make more money, earn more revenue, they're also very keen not to lose users on their network. So I think a learning or an advantage that the Tanzania Partnership had when pitching and having those initial discussions with the mobile operators was, okay, we are targeting a rural environment. We're targeting pregnant mothers, so that's already a subset of your database. But such a service will enable them to stay on your network. And just tackling that very key KPI for any operator, I think it's a door opener for most engagements with private sector and mostly with mobile operators. So the fact that the mHealth Tanzania Partnership were able to demonstrate to the mobile operators how supporting their service and joining the partnership would enable them to keep the user on the network initially for the length of their pregnancy, and then also beyond as they increase more services post-pregnancy and as a child up to, I think now they have content for up to 5 years of a child's age. So as long as the content there is interesting and it's appropriate and it's relevant and it's addressing the user needs, users tend to stay on that network, and it's a pool for them to remain on that network. So I think that's one big approach that catapulted the mHealth Tanzania Partnership to gain even stronger relationship with the mobile sector.
Okay, great. Thanks, Diane. Do we have time for one more question, or are we wrapping it up now? Is there one more question from you? Sure.
Sharing how to spend on a page. I was wondering if you could speak a little bit. I know there's a lot of work going on with the youth partnership and trying to connect the Could you speak a little bit as to how that's moving forward and how partners engage?
This is collaboration.
Yeah. If I can answer that with the investment recommendation.
Yeah, and with our, that's not display that. No, I'll explain. Our vision, first of all, we want to connect all information system used in the health sector. We want all the information system to talk to each other, but we want to have health information mediator, where all systems they suppose or they will link or integrate via that layer. So all for the mobile system, we're going to use mobile platform and connect it to the layer. And this layer will connect to all other Regent systems. For example, the HIS, I'm sure you know about it, EMS, and all other systems. So from there, we can create a visualize system so that we can see all the data from all systems. Right.
All the data owned by the ministry?
Yes, it's owned by the ministry.
The slide you wanted to show?
The last one.
This is just the mHealth platform.
No. Go back. That one. Yeah, this is our vision. You see that health information mediator. So all systems we're going to point to that layer. And all systems are going to talk to each other via that layer. And from that layer, we'll create a visualizer where we can see all data from all systems.
Okay, thank you everyone for.
There's one final question.
Oh, okay. Great. We love questions. This platform is one-way or two-way communication between the provider, ministry, and the user. It's two-way communication. Is there help that support system implemented as well?
Yeah, this platform is two-way communication because, for example, users or end user will register or send SMS and they will receive SMS from the system via platform. And of course, we are in the process of making help desk to support all ICT initiatives in the country, not MLS only, but all systems.
Is that with a separate ministry, or that's going to be with the ministry?
Within the ministry, not separate ministry. Yes.
They want to talk about a feedback mechanism.
Yeah. She reminded me about the feedback mechanism. We have got system right now for the feedback mechanism, whereby our clients, in the health sector, when we say client, it means patient. So when they're going to the clinics or as facilities, they can report back to us the standard of the service they received from the facility workers. Then they can report to us saying if they are asked to give out banners or action, they are abused or whatever. So we can get such kind of information, and with this platform we can analyze that what kind of message is coming from which part of, which side of the country. We can go up to facility level, regional, district, up to facility level.
Great. Well, thank you everyone for joining our discussion today. So I will invite Ophelia to close.
Again, thanks everyone for joining us today. I hope it's been engaging for you. And if you have any follow-up questions, I believe you have all of our contact information, maybe on the materials that you have. And just to kind of close up about PPPs, I want to talk a little bit more about, just very briefly about the way we manage, the way Cardno manages PPPs. And the approach that we take is we provide administrative and financial management. We provide M&E support. Catherine is over there in the corner. If you can raise your hand, she's our M&E manager. And Mohammed, I think he's the only other person on the team that's not here right now. We also provide communications support, which Vance gives us, and also Vance and Catherine both also manage PPPs themselves. So we provide a very comprehensive support to CDC and OGAC in managing these PPPs. We provide a way to value the contributions from the private sector, which is very important, and make sure that it's according to government standards and government regulations. And you can have the best program in the world, but if it's funded by the U.S. government, if we don't make sure that Cardno and all of our partners adhere to all of the regulations and the guidelines of USG, then it's kind of all for naught. So those are the approaches that we take to managing PPPs. And again, if you have any questions, feel free to reach out to any of us. And thank you for coming. Thank you. Over to Tanzania to join us today. We appreciate Renee coming from Atlanta to join us, and thank you very much, Violet Catania, our program manager extraordinaire, and Lauren coming from the State Department. We appreciate it. And we have food out here, food and refreshments, right out here outside the doors. Thank you.
Thank you.